السلام عليكم ورحمة الله وبركاته. آه، شباب ستار دكتور رزق. أنا كنت في الحقيقة برضو في البداية كنت حابب أنوه وأؤكد على اللي حضرتك ذكرته في البداية، فيما يتعلق ب إن إحنا طبعا في هذه الأكتيفيتي العظيمة جدا بنشكر كل الزملاء على مشاركتنا فيها. عايزين ننقلها لبراكتيكال واي، وإن شاء الله بإذن الله يكون في سامبل اوف كيسز افيلابل على منصة رادمي راديولوجي دوت كوم. لكل الليكتشرز او معظم الليكتشرز اللي شفناها النهارده sample cases for reporting, so you can review the case سواء كانت سي تي ام ار اي اكس راي and you can report it. and ان شاء الله اخر ليكتشر خالص هنتكلم على رادمي راديولوجي ريبورتنج تول، وهي في الحقيقه يعني هتدينا فاليو كبيره جدا لان احنا ننقل الساينتفك اكتيفيتيز اللي زي ديت الى براكتيكال واي، واللي من شأنها ان هي تحسن جدا جدا من الاوت كام بتاع such activities، ان احنا ننقل الحاجه للروتين ورك اللي احنا بنعمله. في الحقيقه احنا بنعمل ريبورتنج، وبالتالي احنا محتاجين ننقل التجربه دي تكون تجربه عمليه قدر المستطاع. واشكر طبعا كل الزملاء اللي عملوا شير معانا بالكيسز، وان شاء الله باذن الله الاكتيفيتي تبقى مور كيسز مع الوقت، ونقدر نبني كوريكولم متميز متدرج وبيغطي كل الموداليتيز وكل التوبكس مع الوقت باذن الله تعالى. مش عايز اطول على حضراتكم، نبدا على طول اول ماي ليكتشر. ستارت دكتور محمود. دكتور محمود الهير. Okay. Seems he's going to play. So I'll start my talk. Let's go. Or share screen. Um, طبعا محاضرة النهارده ان شاء الله تكون محاضرة لطيفة ودمها خفيف. وهي طبعا حضراتكم عارفين ان احنا عندنا noisy stuff regarding البيدياتريك ايمجنج عموما. وهي حاجه من الحاجات المزعجه جدا جدا في البراكتس، واز ويل از في الكلينيكال سيناريوز اللي بنتعرض ليها على مدار اليوم في المستشفيات. و وطبعا انا دايما اقول ان البيدياتريك ايج جروب بيجي المستشفى بحاجه من اثنين، يا اما يعني هم يعني مصيبتين اعظم من بعضهم البعض. يا اما جاي عشان ايمرجنسي، يا اما جاي عشان نيوبلازم. حاجات بقى بتاعت كرونيك ديزيز ونوع الفولو اب دي مش كتير قوي في البيدياتريك ايج جروب، زي الحاجات اللي فيها شويه صعوبات كبيره وتشالنجز كبيره، في تحديات كتير، وديفرنشال دايجنوز احيانا معقد ومختلف على along the ages of the babies. هنركز النهارده على الابدومينال ايمجنج ان نيونيتس، لان هي في حته خطيره جدا بتلعب دور كبير جدا ومليئه بالامرجنسيز. ولازم كجنرال راديولوجيست او حتى سب سبيشالايز دايما اكون عامل ريفريش للنولج في الحته ديت، علشان ممكن اتعرض لسيناريو ممكن يكون فيتال ويفكت بيشنت سيفتي امباكت. طبعا احنا دايما بنحاول نربط نفسنا بالكلينيكال بروبلمز، يعني دايما الجود راديولوجيست هو اللي هيقدر يربط الكلينيكال سيناريو بالبرزنتيشن بتاع البيشنت، ويحط كل يعني يركب البيسز اوف ذا ايمج توجذر. النهارده هنفوكس على الثلاثه بروبلمز دول في نيونيتال ايج. اول واحده بتقابلنا مشكله لما البيبي بيتولد، بيكون البيبي ديستريسد او حاجه، ان احنا بنحاول نباص فيدنج تيوب علشان نشور اون سكيور الفيدنج. فبالتالي بنلاقي ممكن يكون في مشكله في باسنج الفيدنج تيوب. هنتكلم على السبيكترم في الحته ديت، لان طبعا في حاجات كتير ممكن تمنع ان الفيدنج تيوب تعدي. هنتكلم على السبيكترم اوف كونجينيتال تراكيوسفيجيال فيستولا او malformations. هنتكلم على one of the common problem بتحصل في التشيلدرن وفي كل الايجز في الحقيقه، وهي الفوميتنج. هنتكلم عليها في النيونيتال ايج او في الايرلي months of life. how to deal with this common وازاي نسلكت البيشنتس اللي هم ممكن يكونوا affected ب serious problems، وبالتالي نقدر نوصل للدياجنوز as early as we can. الثالث مشكلة كبيرة جدا بتقابلنا في الكلينيكال براكتس مع النيونيتس هي distended نيونيت، والفيلير ان البيبي باس ميكونيوم سبيشالي في الفيرست دايز اوف لايف. سو هنمشي نعرض السيناريو كالتالي. هنجيب ايمج ونحاول كده نخلي المحاضرة انتراكتيف. نتكلم على الفيتشرز اللي احنا شايفينها على الايمج، وبعد كده نبدا نتكلم على الباك جراوند بتاع الكيس. I will start with the first image here and I يعني اتمنى ان حضراتكم تشاركوني بقى في الشات ب what can what is in the image، ايه الفايندنجز اللي احنا شايفينها في الايمج، وازاي نتكلم فيها واحده واحده كده ستيب باي ستيب. ان شاء الله باذن الله نلاقي الموضوع ممتع ولطيف. Okay, so we'll start. So this is a chest X-ray in a newborn, and I will ask you simple question. ايه الابنورماليتي اللي احنا شايفينها وايه الفايندنجز؟ اوكي بدأت تندع اهي كويس. Okay, yes, we can see that there is a coiled tube in the upper uh, chest and lower neck. Yes, excellent. coiled tube مش endotracheal tube بقى اللي coiled. ان احنا شايفين ان في feeding tube هي اللي coiled. yes. وان في right upper lung pathology as well. yes. specified channel موجود. احنا في الحقيقه كده شايفين سبيكتروم اوف تايم. في نقطه مهمه جدا، لازم لما اشوف الكويل تيوب اللي انا شفتها في الابر تشيست ديت لازم انا ابص على فين تاني بعد على طول. نيكست ستيب ان انا ابص على ايه بعد ما شفت التشيست، ابص على الابر ابدومن عشان اشوف هل في جازز ابدومن ولا لا. عشان ابدا احط الديفرنشال دياجنوز بتاعها، هل هي اسوفيجيال اتريزيا اونلي ولا هل في فيستولا ديستالي. وبالتالي this is very important to have a look on the upper abdomen if there is a gas inside that downward. So I'm dealing with a fistula as well with this pouch of kinked tube. طيب هنسال سؤال هنا مهم جدا، واتمنى انتم برضه يبقى متاكد في في ايمرجنسي طبعا في الكيس ديت، ولازم ناخد اكشن. هو ايه اول اكشن ممكن ناخده؟ يمكن لو سمعتوا محاضره التيوبس ممكن تعرفوا تجاوبوا الاكشن ده. اتس فيري امبورتنت ان احنا نعمله دلوقتي. مستوعب السؤال؟ يعني في حاجه لازم نعملها دلوقتي حالا. اوكي، الكلينيكال تيم يعملوها وبعد كده نفرزر بروسيد تو المانجمنت او الفرذر ايمجنج. اوكي، اول حاجه نعملها يس ان احنا نوذرو التيوب ديت ونركب التيوب الدبل هيومن تيوب او التيوب اللي بيبقى فيها سكشن علشان نمنع الاسبيريشن. غالبا ده ممكن يكون كولابس دي تو اسبيريشن او يس عشان نعمل سكشن اكسلنت للسلايفا اللي موجوده في الاسوفيجيال باوتش الانكلودد ده، تمام، اللي حصل لها اكيوميليشن، وبالتالي ممكن تعمل اسبيريشن، ومن الاسبيريشن مش هتدخل في كولابس واذر sequences of disease. So this is the first image احنا عملناها which is very nice. دلوقتي هنتكلم بقى على الاسوفيجيال اتريزيا والتراكيوسوفيجيال فيستولا. If you can see here that there is طبعا احنا عندنا الاسوفيجس اليومن لوحده والتراكيا اليومن لوحده. المفروض الاثنين ما يبقاش فيش اي علاقه بينهم. اوكي، التراكيوسوفيجيال فيستولا على عكس حاجات كتير بتحصل بري تيرم، دي بتحصل في 10 بيبيز، بتحصل في ايج اكتر من 38 ويك. وال غالبا الفيستولا بتحصل بينها وبين التراكيه او الريسبيراتوري تراكت، وغالبا البيشنت دول بيبقوا عندهم بولي هيدرومنس، يعني المذرز بيبقى عندهم بولي هيدرومنس. وطبعا من الحاجات المهمه جدا طالما جات سيره توف او جات سيره اتريزيا ان احنا نفكر في الاسوشيشن اوف السندرومز اللي بتبقى associated with this such kind of pathologies. زي الفرتبرال انوماليز وزي اتريزياز زي كارديك انوماليز زي رينال انوماليز. كل ده لازم نعمل له سكريننج with a very good approach. طيب هنا مهم جدا ان احنا نعرف التايبس اوف توف او تراكيوسفيجيال فيستولا او الفيستوجيال اتريزيا السبيكترم اوف ذيس ديزيز. اتس فيري امبورتنت. الموست كومن تايب طبعا، ودايما وانت بتذاكر او بتراجع او بتراكتس دايما فوكس على الموست كومن، لان الموست كومن ده هو الاوقع انك تقابله وهو يبقى اول حاجه في اختيارك. try to براكتس لايك ذيس وان، دايما تبقى عارف الكوزز بالموست كومن، لان الموست كومن معناه انه بيتكرر كتير، وبالتالي لازم ابقى عارف كل الفيتشرز بتاعت الديزيز اللي بتيجي في الموست كومن تايب. اذا اتكلمنا على الاسوفيجيال اتريزا والديستال توف او الديستال تراكيوسوفيجيال فيستلا، ده بيشكل الماجوريتي 85% من التايبس اللي هم تقريبا 5 تايبس. وبالتالي انت بيبقى عندك خلينا نعمل البوينتر بتاعنا هنا. اوكي عشان يبقى معانا لطيف. اوكي انت شايف هنا شايفين بوينتر معايا؟ لو كده ادي الباوتش اللي حصل فيه الكينكي تيوب هتيجي تنزل مش هتعرف تكمل، وبالتالي هتبقى كينكي هنا. التراكيه بعد كده وات ايفر بقى جه منين، من اي بارت من التراكيه او من البرونكاي ممكن يحصل كونكشن بينها وبين الديستال بارت اوف ذا اسوفيجس، وبالتالي البيشنت هيبقى جاي بديستنشن في الابدومن كمان as well due to accumulation of air inside the gastric الكات كلها تبقى filled with air very massively. السكند موست كومن تايب هو البيور اسفيجيال اتريزيا without any فيستلز، وبالتالي الفيتشر هنا ان البيشنت ده مش هيبقى جازلس، مش هتشوف اي جاز في الابدومين خالص لان مفيش اي حاجه توصل الاير للباول، وبالتالي this is a very nice clue. عشان كده الاير very important in the abdomen ان احنا نديلينيت الاذر الكوزز. طيب عندنا ايه اذر تايبس؟ عندنا الاتش تايب في السؤال اللي معظم الناس بتبقى حافظاه، وغالبا الاتش تايب ده مش بريزنت في النيونيتال ايج جروب وبيجي ليتلي ان ذا تشايلد هود، وبيبقى غالبا جاي بفيتشرز بقى اوف اسبيريشن او ريكارنت انفكشنز، وبالتالي one of the differential diagnoses اللي must be included in childhood لو البيبي بي او التشايلد بيجي بمالتيبل episodes of chest infection. ودي طبعا سبيسيفيك واي هنتكلم عنها في الايمجنج. الاذر رير كوزز او تايبس ان يكون في دبل فيستولا، ان يكون في بروكسيمال فيستولا في الابر اسوفيجس، وبالتالي this rare types يعني نيرلي مش بنشوفهم بسهوله in the clinical practice. اوكي سوجيال اتريزيا هنا جبنا بقى الايه الفيتشرز اهيت. الكولابس طبعا اللي بيحصل هنا او الكونسوليديشن غالبا ممكن يبقى كونسوليديشن ديو تو الاسبيريشن، او يكون كولابس ديو accumulated secretions او in the bronchus، وبالتالي البيشنت هيدخل في spectrum of respiratory distress as well due to infection او due to collapse. So this is an emergency ولازم التيم يبقى يتعامل معاها بطريقه مختلفه زي ما هنتكلم عن المانجمنت دلوقتي ازاي هنتعامل معاها. This is another image. عايزين بقى الكلام يروح في البوث ويز يعني في الدبل واي، عايزين نشوف برضو ايه الفايندنجز اللي احنا شايفينها هنا. You can see it clearly. Yes. Isolated tough. Gasless abdomen, yes. No gastric tube. Gasless abdomen, yes. Okay. Okay. هو in fact um, I know that the resolution of the image is not good, so good. So هو في some sort of nuisance here. Yes, and there is في الحقيقة في تيوب هنا لو احنا حاولنا نرسمها هي كده صعبة شوية هي دي في الحقيقة السكشن تيوب اللي هي اتكلمنا عليها، وعندنا جازلس ابدومن في الحقيقة ما فيش فيها أي اير، وبرضه التشيست في some opacity especially in the right perihilar region especially in this area. So this is will represent the features of the esophageal atresia or pure esophageal atresia as we discussed. Okay. So this is a pure esophageal atresia, and here there is a pouch. Here is a tube. You can see it now, I think, clearly as we discussed now. Okay, and there is also some abnormality here in the right parahilar region or perihilar region, representing early infection or something like this. ديتول الباوتش ده طبعا انتوا عارفين الباوتش ده بيبقى باوتش صغير جدا، والبيشنت عنده السلايفا بتاكيوميليت تنزل تفل الباوتش وتبدا تسبل، وبالتالي تنزل في ممكن تنزل في الاير واي، وبالتالي ممكن البيشنت يدخل في اسبيريشن through this process. Sorry, I need to stop share for a second. Sorry for that. Okay, I hope that the screen is clear now. Yes. Sorry for that. Continue on. So now this is the spectrum as we told. Now the late problem that will happen in these cases that the patient will be presented with recurrent chest infections in this kind of disease. Here, if this happened, we will think about H-type fistula, and this condition we need to image the upper GI with a specific protocol to catch this. So the important issue here, if the patient is presented with recurrent infection, a list of differential diagnoses will come in our minds. One of them must be included, the H-type fistula, which is representing about 5% of the whole esophageal spectrum of the tracheoesophageal malformations. And this is very important. With sequestration, with the other causes of recurrent infection that come in our minds when such abnormality is there. Okay, and here is a study that we do for the H-type. So anyone know what is how we image the baby or the child for this abnormality? Can you type it in the chat? How we image this child to know where is the location of the fistula H-type, because what happened in the H-type is the two lumens are going directly, so the patient is taking his feeds without any problems. His airway is good without any problem. The small connection between them in part. So let's discuss this later. Okay, so here is the esophagus. Okay, we introduce a feeding tube to the stomach, and we start inject the non-ionic contrast, and we withdraw the tube during the injection under fluoroscopic imaging. Then this is the lumen is filling with the contrast. Okay, we are pulling the tube up. We are pulling the tube like this one and injecting the non-ionic contrast, water-soluble contrast media, and then, okay, please stop annotation. Okay, and here we can see that there is something is coming here from the esophagus, which is abnormal, and it's entering to the chest. Okay, so this is a contrast is filling the bronchial tree. Okay, so this is what we do to make the diagnosis of H-type, which is very difficult and challenging in the routine practice. Okay. Okay. And here is the fistula. Okay, this is the fistula between the two lumens. Okay, and here also another cases that represent that the patient is having the spectrum of malformation, and the patient is having multiple anomalies representing syndrome. So the patient is having an obstruction at this level, and he is also having obstruction up. So the patient is having multiple atresia along the bowel. So it's very important when you catch one of these abnormalities to complete your search for another congenital anomalies. Okay, another case here. Okay, we have the pouch here, and also we have abnormality in the liver. So we don't have the radius. with the thumb is not appearing here. So this is radial array is not there. So the patient is, and also you need to comment on the cardiac shape. You need to do an ultrasound or to compare with the previous imaging of the patient antenatally, especially for ultrasound, and if there is fetal echo cardiogram done for the baby. And if not, you need to proceed for this all and doing the skeletal survey, always stop for this issue. Here to move quickly to the management of this esophageal atresia, it will depend on the type of the esophageal atresia. In fact, so the baby who is presented early with esophageal atresia with distal tracheoesophageal fistula or having a pure esophageal atresia, this baby is having a serious problem. This is an emergency, and the patient will need to go undergo a primary anastomosis in 24 to 84 hours of life. So the patient will need an urgent action. So to catch this, you must be very clever in the picking this abnormality in fact. So in some cases, like pure esophageal atresia, we can do a feeding gastrectomy. It will allow the esophagus to grow up to be in the chest, and we will do the operation after 6 months. In each time, the patient will need to ligate this fistula, and this is not massive as the other types of esophageal atresia with this problem. So مشكله من المشاكل العظيمه اللي بتقابلنا كراديولوجيست ان المشكله مش بتنتهي معانا لما البيبي هيعمل الاوبريشن وخلصنا كده. لسه هتبدا معاناتنا في الفولو اب والكومبليكيشنز اللي هتحصل نتيجه اني بروسيجر او any surgery او any intervention. So we must know the spectrum of the disease and the complication will happen after it. So وده اللي مخلي الكوريكولم بتاع الراديولوجي بتاعنا كده عظيم الشأن كبير، وبالتالي it's very good to have a wide knowledge about the complication of these diseases and the complication of these surgeries. So it can be anastomotic leak, and this can be need to be imaged again with contrast swallow. The patient will be managed according to the level and the amount of this leak. Could be anastomotic stricture at the level of anastomosis, and the patient will need to be treated with balloon dilatation. Also, pneumothorax, as in this case, can happen from this intervention, and aspiration as well can be one of this problem. So the patient is having here marked pneumothorax, and it's in fact tension 1 because there is shifting of the mediastinum to other side, and there is also a flattening of the posterior diaphragm. So the patient is having this kind of tension pneumothorax. And later in the childhood, the babies in this level will have problems with gastroesophageal reflux because it's very common with these babies. So the patient will be managed according to these problems. Also, respiratory complications can happen also in these scenarios with bronchial hyperactivity and the asthma. The patient will need to also have increased risk for respiratory infections when he is going through the life. So another cause and another clinical scenario. Okay, can anyone tell me what is happening here? Okay, so one of the important checklists in our practice with ultrasounds in neonates and early child, excellent. Okay, bar rotation, yes, because this is an abnormal location of the superior mesenteric vein as compared with the superior mesenteric artery. So we'll go through the images and to know what is happening. Yeah. So this baby's coming with vomiting, which is a very non-specific sign, and it's a very common clinical scenario that the patient is coming with vomiting. And unfortunately احيان كتير بيكون ده indication ب serious problem, وده طبعا بيبقى cooperation between the clinical team or the clinician and the radiologist. Okay, and الإيمجينج بيلعب رول كبير وعظيم جدا to determine the underlying cause, وبالتالي نقدر نروح للمانجمنت as possible أو as early as we can. طبعا الالترا ساوند هو الموداليتي او الفيرست ايمجينج موداليتي اوف تشويس in this space, and you must know the checklist when you are performing the ultrasound. You must know and arrange the checklist because احيانا احنا بنعمل السونار بطريقه بتخلينا نروح روتين. لا، لازم طالما البيبي جاي لي بكلينيكال سيناريو معين لازم يبقى عندك تشيك ليست. هذه التشيك ليست لازم اعمل لها اكسكلوجن كلها، لان ممكن يكون انا اللي عميس الابنورماليتي دي، وبالتالي البيشنت ممكن يسافر from this issue. فالالترا ساوند ايمجينج هو الموداليتي اوف تشويس في الحقيقه، وهو الفيرست لاين اوف ايمجينج ان vomiting in a baby with vomiting. And if we needed to do an X-ray, abdominal X-ray, it can help. Other modalities also will depend on the scenario. It will come and help us also to reach a final diagnosis. You need always to ask about the clinical context in this patient. Okay, here one of the important serious problems that you need to exclude. The first thing that must come in your mind is to exclude malrotation. In a sick neonate is very important, and it's a radiological and surgical emergency for all patients عندهم potential لهذه الأمراض، لأن الديلي ده هيؤدي إلى total gut ischemia which is a serious, and هيبقى معاها mortality عالية جدا جدا جدا. So don't miss this one. And here is the anatomical distribution of the duodenum, and from the X-ray, if you are doing an X-ray or doing upper GI study, this is will be very nice to know the anatomy in this image. So you have the stomach and the duodenum starting to pass on the right side of the vertebra, and then the duodenal junction will be on the left side of the vertebral column to near the stomach. Okay, so there is normal location here of the terminal ileum in this area with appendix. So in the right iliac fossa you have the normal appearance of the cecum with terminal ileum and the iliocecal junction. So this is the normal situation. In non-rotation, this will be a flipping of this scenario, and the patient will have a very serious problem due to this one. Okay, very important to know that the patient with malrotation will come with non-specific symptoms sometimes, and sometimes he will be with a very specific one. So the patient may come with bilious vomiting, which is a vomit with stained with bile, and may be presented with upper GI obstruction or our gut obstruction. So what is the most common finding that you will find in the abdominal radiograph? Okay, it's a normal radiograph. So a normal radiograph is the most common imaging criteria. So لو البيبي جاي بفوميتنج والفوميتنج ده bilious vomiting، وانت الانستتيوشن بتاعتك او المستشفى بتاعتك او المركز بتاعك او وات ايفر اللي انت بتشتغل فيه ادى وقال ان عملوا request abdominal radiograph, والabdominal radiograph is normal. So you can't exclude serious problem like malrotation, and you need to go for ultrasound to be sure about this, because this is a modality of choice. But in some cases, you will find another features that can suggest that the patient is having a malrotation or mid-gut volvulus, like this one. So you can find gut ischemia, which will be represented by and gut edema. This both will be thickening of the wall, and there is nematosis intestinalis. You can find abdominal fluid ascites in the abdomen, and you can find the duodenal obstruction with large one bubble sign, or double bubble signs like the duodenatresia. You can find a bowel obstruction due to the malrotation, and sometimes there is bands there, so it will complicate the process. Also, you will have maybe you have a right-sided small bowel, because in malrotation, the small bowel, all the small bowel will come to the right side, and the colon will go to the left side. But these signs may be lately in the adulthood or in the older child, you can see them. But in neonatal age or in the early infancy, you can see this last two signs effective. Okay, and here one image, and this is another one, and this is the third one. So this is the same baby. The baby presented firstly with this image, and then he presented again with this image, and we did an upper GI study for him. So the patient is represented with bilious vomiting, and there's non-specific imaging in the abdominal radiograph at firstly, but after that we did a barium or upper GI study, which is not barium, to use a water soluble contrast medium. So we found that this small bowel on the right side and the large bowel is noted on the left side completely, and the patient was in malnutrition. Okay. So here the ultrasound rule, okay, and this is a normal anatomy and pathological appearance and malnutrition. We need to see the superior mesenteric vein on the right side of the superior mesenteric artery. So you can follow this and know this by the anatomy by seeing the splenic vein joining the superior mesenteric vein, and together they are doing or making the portal vein. So you need to be sure about the anatomy if you are confused. Okay, so the superior mesenteric artery will come from aorta as well, and usually you will follow them the both structure to be sure which one on the right side or on the left side. And in malrotation, there is one reversal of the normal axis between superior mesenteric artery and superior mesenteric vein due to failure of due to flipping of the mesentery, so it will take the vasculature with it. So it's very important, and it's very important to follow this along the side. So you need to follow this from the origin until to see it at the level of the pancreas to be sure about this is a malrotation. Sometimes it's very pitfalls in this imaging evaluation during your performance of this case. And here is the abnormal location. Okay, so here you can see the artery and the vein is flipped to be more anterior to the superior mesenteric artery, and can be on the left side. So it will be very characteristic to be to denote that the patient is having malrotation. When you saw the swelling sign in the ultrasound, that means that the patient undergo to volvulus, and very important here that we have two entities. It's not one entity. It's a malrotation. Malrotation is a congenital problem that can present, can happen in the baby and happen congenitally, and the baby هيعيش بيها عادي خالص. ممكن ما يجيش الا في الادلتهود خالص، ما عندوش اي مشكله، بيجي بكارنت البين وبتاع تكتشفها انت في الادلتهود عادي خالص جدا، ما فيش اي مشكله. لكن المشكله بتحصل فين؟ ان غالبا البيبيز دول ممكن يدخل في ميد فولفلس في الليت نيونيتال ايج. اوكي، ايه اللي بيحصل؟ ايه علامه الفولفلس؟ انك تشوف السوير ساين، ان الميزنتري ده يلف اكتر على بعضه، وبالتالي البيشنت يدخل في اسكيميا and so on. It will be very serious. So المالروتيشن اتسلف مش هو اللي احنا هنخاف منه اكتر حاجه، بقدر ما احنا هنخاف اكتر من الفولفلس. اوكي، ف very important ان احنا نبقى focusing على الفولفلس او الميد جاد فولفلس which is the serious problem in this situation. And here is one of the most common studies that we can do and which give us a very characteristic imaging features, and it will give you the different diagnosis also using the upper GI study, using fluoroscopy. And if you are in doubt about the volvulus, you are not sure about the swirl sign, so and the patient still unwell, you need to go further to do upper GI study. And here you can find that the duodenojejunal junction is on the right side of the spine. It's not on the left side as we saw in the in the diagram, and there is a corkscrew appearance, which is representing the twisted bowel around the mesentery and during the volvulus, and this is a serious problem, and the baby will must need to go immediately to the surgical room or the OR for operation, and you need to urgently inform the referring physician about this finding. Okay, still we have the baby or the child who is coming to the clinician, this time with non-bilious vomiting. And this is the appearance that the patient presented with. So what do you think is coming, and what is the cause of this non-bilious vomiting? You can tell me on the chat. Okay, start coming in the chat. Yes, excellent. Yes, excellent. Yes. So we can see here in this image, there is thickening of the pyloric canal in transverse scan and in the longitudinal scan, which is representing another serious problem that we need to take an action regarding it. So let's move. Okay. So idiopathic hypertrophic pyloric stenosis, also one of the serious problems, and it will come with non-bilious vomiting. Patient will be presented with a projectile vomiting. Classically, the patient must be presented at 6 weeks, but الحقيقه شفنا عيانين من 2 weeks و 3 weeks، وشفنا عيانين عندهم 6 months، فايتس 3 months، فهي في الايج جروب between 2 weeks or 3 weeks most commonly coming between this between this range of age. So ما فيش حاجه في الحقيقه فيكسد يعني ولا ثابته. It can be okay, and the differentiation between pyloric spasm and the spasm and the CHIPS or hypertrophic pyloric stenosis will be with the measurements. So the classic presentation that the patient will come with projectile non-bilious vomiting, and the patient will starting this infrequent, and then after a while the baby will project this vomits with every feed. So the patient will go through a very serious problem of dehydration and lethargy. So the patient will need to be managed immediately. And if you are not sure about your imaging finding by ultrasound, which is very challenging, in fact, and it will need you to be patient and to have a very good experience dealing with this. And you must know that I know that the measurements is having a wide range. Many of our colleagues are asking which one is the one, but there is variability between the sites of textbooks. So this is the most standard in the UK. So we are considering this as UK. So you need to measure the single wound, you need to measure the double wound width, you need to the whole width, and you need to also measure the whole canal length. So, and there is a lot of signs. There's cervical sign or vagina signs. They are typical signs of this. It's simulating the vagina with uterus. So it's very characteristic one. You can use it in your diagnosis. And here you can see that the length of the length is exceeding 23 millimeter, and here you can see that a whole length is exceeding 14, and also single wall is exceeding 4 millimeter, which is indicating that the patient has positive idiopathic hypertrophic pulmonary pyloric stenosis. Other tests that we can use when we saw abdominal radiograph, we suspecting that the patient is having a serious problem in vomiting. It can include barium meal. This is especially with the other causes of upper GI obstruction, because we have a lot of differential diagnosis list. In fact, we have aneurysm pancreas, we have maybe the duplication cyst. We can have, if we are excluding the primary diagnosis of duodenal atresia or atresia in the first days of life, this can happen in the late days of life. or in the late neonatal period, the annular parenchylias will cause partial obstruction. It will not cause complete obstruction. So you are expecting to see a few gas bubbles in the distal abdomen. So it's not a complete obstruction. Also, if there is a duplication cyst, it can compress the duodenum at the level of the duodenum. It can cause a partial obstruction as well. So you can see that the baby is presented with vomiting, with late presentation of this abnormal. So you can proceed to other imaging if ultrasound or is not helpful and is excluding the other two serious possibilities that will need surgical management immediately. To others using maybe barrier knee, and this will expose the baby to radiation. So you need to postpone this until you need it, and ultrasound is better for most of the differential diagnosis. Never requesting CT scan unless this is very serious issue, because CT is not helpful. In fact يعني مش هيدينا معلومات كتير وفي الحقيقه هيحرق العيان يعني، فاحنا مش محتاجين ان احنا proceed to this much radiation. Okay, this is another image. I know that maybe the image is not, resolution is not good, but we hope you can see anything. What is the main concern now? Okay, anyone can report in the chat or tell me in the chat what can we see? Hemoperitoneum. Okay. Oh, bowel obstruction. Yes. Okay. Neck. Okay. Okay. Any other? Okay, multiple fluids. Okay. Okay, I will start with your description. It's very important to know how to report such case. And you know that sometimes it would be a very noisy to have what is the normal bowel pattern, and it's many times أو في غالب الأحيان بيبقى الموضوع confusing في الحقيقة جدا. هو ده normal ولا abnormal? So it will be in combination with the clinical data. So if the baby is in first days of life and the baby لسه مولود وفينينج في باص ميكونيوم وفيه abdominal distension وانا شايف ان في relative dilated bowel وهنعرف ازاي نزنق مع الباول ده dilated ولا لا. I must start to think about the congenital causes or the causes of intestinal obstruction or bowel obstruction or lower GI obstruction in the neonates. And you know طبعا عارفين ان احنا عندنا two differential diagnoses في الحقيقه في الايج جروب ده. It's between upper GI obstruction and lower GI obstruction, and you need to differentiate between them. Okay, اتكلمنا على upper GI obstruction especially in the late neonatal age. في الابر اللي هم كانوا التشابس وكان الماريتيشن بالجاد فولفلس. في الايرلي لايف هيبقى تيجينا اتريزيا والحاجات اللي زي كده. طيب في اللور جي اي بقى عندي برضه وايد ديفرنشال دايجنوزز وبيعتمد على الايج از ويل. لو البيبي في فيرست دايز اوف لايف ولا بقى، فالابدومينال ديستنشن في الحقيقه اللي بيجي بيه العيان سبيشال في الفيرست داي اوف لايف بيحمل a lot of differential diagnoses. منها ان العيان نورمال خالص ومش اي حاجه ويعيط كتير وعنده مغص فبيبلع الاير وبالتالي الابدومين بتبقى very distended. So it's very important to know that it can be normal. Okay, sometimes لو البيبي عنده esophageal atresia زي ما كان he swallow air and this air with esophageal fistula and with distal fistula the gut will be filled with air and the gut will be distant. لكن في differential diagnosis طبعا yes we have very large differential diagnosis of abdominal distension. In fact واحده منها طبعا اهم حاجه فيها انه طبعا الباول، لكن ممكن يكون ماس ليجن زي الهيدرونيفروزز اللي هي موست كومن. فور اكزامبل الماس دي ممكن تكون من الرينال، ممكن تكون من الليفر، ممكن تكون كوز البروبلم اللي جاي بيها العيان just distension. لو البيبي جاي بديستنشن في features suggest ان البيبي عنده some obstruction او ileus, it will be ان البيبي مش بيباس stool or مش بيباس meconium. It's very important to know the whole clinical data before reporting such cases. طيب ايه الكوزز الثانيه اللي عندنا؟ عندنا السيبتيك ileus من الحاجات الفيري كومن ان نيونيتال ايج جروب، واللي هي نون اوبستراكتيف كوز، هي reduced sepsis reduced peristalsis. البيبي بيدخل في some sort of dilated bowel which it can lead to later on necrotizing colitis. Also, ascites can be a very common cause of distension, especially لو البيبي عنده hemolytic anemia, which is very common in the neonatal age with sepsis from hemolysis, and the patient maybe also due to congenital infection can have a very serious problem with hepatosplenomegaly as well associated with ascites. If the patient is having cardiac failure, with most of the neonatal age babies اللي بيبقوا admitted in the hospitals بيبقى عندهم some sort of cardiac disease، وبالتالي لو البيبي دخل في cardiac failure also it will lead to ascites. And together with the clinical scenario of failure to pass meconium, it will be a very serious problem and must be excluded, especially in the first days of life, to ensure that the patient is not having a lower GI obstruction or distal obstruction. So here is another image of a baby, which is showing normal gas. So we saw an image from the beginning, and this is another one. It's very confusing. It's a normal bowel. So how to determine which one is abnormal? It's a very important and serious one. Let's go to know. So firstly, we'll start to discuss some cases of dural distension, and the patient is presented with a specific feature that suggests one of this diagnosis, and then we'll go to the most serious problem, and how ازاي differentiate between normal gas pattern and the dilated bowel. Okay, so أول حاجة عندنا دي double bubble sign. It's a huge distended stomach. Okay, and other bubble is representing that the patient is having most likely duodenal atresia. And don't forget in this scenario ان انت تبص على ايه؟ على الحاجات اللي associated مع such appearance او such disease like Down syndrome, like bacterial. فتروح تبص على الفرتبرا، تروح تبص لان ممكن you are the one especially in our country. في مصر طبعا ممكن يكون البيبي مش عامل very good work during the antenatal period, so you will be the first one to capture this abnormality. So it's double bubble sign. And here also you can see that there is relative dilated bowel view, and there is a mottled appearance of the bowel. Okay, and if you are concentrating, I know the image also resolution is not so good with to expansion, and here you can see that that there is maybe a pneumatosis intestinalis. Okay, after a while, this is the same patient. After a while, the baby entered to pneumoperitoneum as a complication of this such abnormality. So in the beginning, the baby is having necrotizing colitis due to the accumulation of this midgut, of this mottled appearance representing pneumatosis intestinalis, and there is air also over the liver, the channel. There is branching air representing portal venous gas, and after a while, the baby in the follow-up studies, the baby is having a very massive pneumoperitoneum with characteristic signs of pneumoperitoneum of football sign, regular sign, and also is having falciform ligament sign. So all the signs are encountered in one image. So this is very common to know that this serious pneumoperitoneum signs. It's very important in your practice. Here, another very common and common image finding is that to see a dilated bowel, and the dilated bowel is identified by the first interventricular distance. Measure المسافة بين الفيرست لمبر interventricular distance، وبعد كده تروح تبص compare it with the other bowel dilated، هتلاقي ان لو هو اكتر exceeding الفيرست interventricular distance. So يبقى انت بتتعامل مع intestinal obstruction، تبدا تدور على الكوز obstruction. You will find it here, which is an right inguinal hernia causing strangulated and causing obstruction. You need to follow to check the features of pneumatosis intestinalis. If the patient is having any mottled appearance, or if the patient is having pneumatosis intestinalis, this is a very serious, denoting the patient entered into feature of ischemia. And here back to this image, and here is the how to rule of thumb, how to be sure that the baby is having intestinal obstruction than the big baby having dilated bowel as compared with the first interventricular distance. And this baby, after doing a lower GI study, and we find that the rectum is normal in caliber. Yes, okay, you can start the evaluation of the lower GI study with from the rectum because we're injecting the contrast from retrograde from the rectum. So we start with rectum to exclude Hirschsprung disease. So if the rectum is normal in caliber and dilated, so you can proceed to the rest of the bowel, and you'll find that the whole colon is a small caliber. Okay, so the baby is having, okay, a microcolon, and the microcolon having a differential diagnosis of Meconium ileus ileal atresia. So we need to follow the contrast, and after the cecum, it's being applied in the pouch. So this was an ileal atresia, and you need to also exclude any associated abnormalities in the vertebra, in the bones, in the renal. This can be part also of syndrome. So you need to exclude this one. Quickly, we'll go through some images, and here also there is a dilated bowel loop, absent distal gas, and the baby is having failed to pass meconium in the first days, and there is of life. And after we did and inject contrast in the bowel using water soluble contrast media, we find this image. So anyone can tell me what is happening here? The baby in the first days of life failed to pass meconium, عندنا dilated bowel في الإكس-راي، عندنا absent distal gas. We inject a lower GI study, عملنا lower GI study. So what do you think? What is happening? Okay, let's go through our approach. Okay, the rectum is normal because we can see it's normal in size and shape without any serration, suggesting Hirschsprung disease. Excellent. Someone is, he got it. We have a small left colon, is a small in caliber, and then the caliber start to be normal with maybe dilatation. So the baby is having left small colon syndrome, which is due to a plug happening here, okay, and the plug, okay, is a cause of obstruction. Okay, so this is a meconium plug syndrome, the lazy colon syndrome, the left small colon syndrome. The three names are true for this entity. And I hope I think I am starting to be late, so I want to go through it very quickly. So it's very important to happen because it's happen in the premature infants or babies, and especially if the baby is his mother is having diabetes. So the patient's meconium will start to accumulate and be lazy. So the colon start to be lazy. Due to is not there is obstruction of proximal to the left colon, so it will be lazy, not working, so it will be small caliber. Don't tell differential diagnosis بتاع الهيرشسبراينج مع السمول left colon syndrome must be treated very carefully because you know that the patient in Hirschsprung disease or meconium ممكن يحل اللور في اصلا ممكن يحل البروبلم. فالديفرنشال دايجنوز فيري امبورتنت هنا، ولازم ان احنا ناخد بيوبسي علشان نبقى متاكدين مفيش هيرشسبراينج ديزيز، وان البيشنت ما يروحش وهو عنده still the problem is still there. So this is a very important issue. So discuss. Here another case. Anyone can tell me what is happening here? Okay, excellent meconium peritonitis. We can see a sheets of calcification here, and the there is a sheets of calcification here in the periphery of the abdomen. It's staining the whole abdominal cut, sheets of calcification, which are representing that the patient may have in utero perforation, which is due to standard obstruction. So we need to further investigate the baby to know if there is any problem happening inside. So you will find that the baby is having microcolon as well, but there is a multiple filling defects, and contrast is passing to the terminal ileum. Okay, so the baby is having meconium ileus, and this is associated with meconium. Meconium peritonitis is most commonly associated with meconium ileus, and if you got the meconium ileus differential diagnosis, also you need to go and ask for other associated criteria like cystic fibrosis, and this is very important to manage through it, so you can try to get this and follow the patient. Okay, this is another case. I want to move. Some of these cases will be on our website for you to report, and you'll find the final report. I want to go to this important issue before closing this session. It's the necrotizing enterocolitis, and I want here to illustrate that the necrotizing enterocolitis features in ultrasound. It's very important because we are now doing ultrasound as a modality of choice for detecting even the very early stages of necrotizing enterocolitis. Once the baby started to have sepsis, there is a distension in the abdomen, they will start calling us to do an ultrasound. We start to, even with using Doppler, and this is maybe advanced, we can predict that the baby will go to necrotizing enterocolitis from the Doppler studies of the mesenteric vessels. However, if we are focusing on the features of established or starting from early diagnosis of necrotizing enterocolitis until the later stages, and here is the Doppler appearance and the appearance of the wound of the bowel along the necrotizing enterocolitis pathway. And if you can see that it will start with hyperemia because of the need of the gut to overcome the problem. So there is a very aggressive hyperemia in the wound, and this is to be the starting one, and you will find in the ultrasound with thick wound and edema, and you will find the very hyperemic wound. Then with the late progression of the disease, you'll find that it's starting to have a slough, and the nematosis intestinalis will start to happen, and necrosis will happen, and the wound will be very thin, and then this will indicate that the baby is a very high risk of perforation, and if the baby is perforated, so mortality will increase to 60%. So it's very important to know the ultrasound features, and here is an illustration of the difference between abdominal X-ray finding and abdominal ultrasonography. Ultrasonography is very important and very sensitive, in fact, but X-ray is very easy in the neonatal units, and many times an expert is not available to evaluate the patient routinely with ultrasound. So ultrasound is kept for the more complicated issues. Both of them, ultrasound X-ray, play a very important role in the evaluation. And once you are early in the disease, ultrasound is very more helpful than X-ray. It will give you a view about the peristalsis, if there is peristalsis or not. It will give you a very good evaluation of the hyperemia. Also, it will allow you to know if there is perforation as well. Even in X-ray as well, you can find a very common tool for evaluation of nematosis and also the bowel stasis and illness. And here in the nematosis intestinalis, okay, in the bowel wound, you find in the profile, the image is image in profile, so you will find it as a mottled appearance like this one. So don't neglect this appearance. Sometimes it will not be very obvious in the wall. It will be only like this one. So you need to consider further evaluation by ultrasound. And here you can find that the sick wall with echogenic foci with comet tail artifact of the air. So the baby is having thick wall with pneumatosis intestinalis in the wall, and here you can see it in the longitudinal section as well. So it's very characteristic, and don't mix between the air inside the lumen and in the wall. It's very tricky, and you need to practice more and show a lot of images and show videos of this one to illustrate the difference between intraluminal air and the wall, the air in the wall. It's very tricky, and especially if the bowel is collapsed. In another scenario of pneumoperitoneum, okay, and there is pneumatosis intestinalis, and there is features of pneumoperitoneum. If you can see that there is air over the liver, okay, and there is also a regular sign presented in this case. So the patient is perforated, okay, and this is a regular sign. You can see it, and you can see that the wound is clearly and the air between on both sides. Transform ligament is not appearing here very well, so it's a fortunate sign the patient is having pneumoperitoneum as a neck. And here also this is representing portal venous gas in the ultrasound. You can see that the echogenic foci is reaching even to the surface of the liver, denoting that it's a port in the portal chains. So portal channels. So this patient is having portal venous gas, and here is perforation. You can see that the wound is having pneumatosis intestinalis, and there is a perforation with layering and turbidity, suggesting that the baby is having fluid, which is turbid, and the patient may have peritonitis. And here is hyperemia of the wound in early stages of the disease. Here you can also see the hyperemic areas of this wound, suggesting that the patient is having necrotizing enteritis. Thank you. And waiting you again next session بقى مش next week. The patient is طبعا هيبقى في sample of images على الليترشر ديت موجوده على radiology.com بعد المحاضره. وقت المحاضره ان شاء الله انا هكون معاكم برضو افرجكم على الويب سايت وازاي هنتعامل مع السامبل اوف كيسز اللي الزملاء اعطوه لنا النهارده. حياتي لكم، طولت عليكم، سامحوني. كل سنه وانتم طيبين، نشوفكم على خير. دكتور محمود المايك معاك.
Thank you so much, Dr. Mohamed. Very amazing lecture as usual from you, and comprehensive. Like a pediatric review for abdominal imaging in neonates, mashallah. I think this is very nice for the preparation for the exam. Someone will go through the Viva cases. I think he will have one of those cases in the exam for sure. So that's nice that you make good review also for our candidates who will be in the exam soon, inshallah. Thank you so much. I think now we have short break for 15 minutes, and after that we start lecture. It will be about hybrid imaging in pediatric oncology. I hope that will be nice. It will be after 15 minutes. So let's start together, inshallah. Wait you there, inshallah. Assalamu alaikum.